Good day, everyone. I am Ronald, the moderator for this webinar. I welcome everyone to today's webinar that will be on chronic care management. What do you need to know to design and implement a successful program? I want to introduce our presenter for today. That will be Dr. Irina Kaufman. Dr. Kaufman is a nurse practitioner and a doctor of nursing practice with 25 years of nursing and 15 years of executive experience. Dr. Kaufman is a subject matter expert in chronic care management, remote patient monitoring, RPM, and care coordination. I would now like to hand over the floor to the speaker. Over to you, Dr. Kaufman.
Thank you very much. Hi, everybody. Thanks for coming. CCM has been a hot topic for a while, so let's dive right in. And today we will discuss chronic care management. I will be calling it CCM going forward. I will also discuss principal care management, which is a PCM, and we'll talk about that in a little bit. We will go over all of the scopes of services, what it is that you need to know in order to successfully build and bill for this wonderful program. And we'll talk about the successful implementation plan and evaluation plan. I always like to start with a little bit of history to understand why certain things were designed and implemented, and that can help you maybe understand how to use this program going forward. So I'm not going to read the statistics, and I'm sure you are aware that half of Americans have at least one chronic condition, and 25% of everybody, adult Americans, have two or more chronic condition, but 75% of Medicare patients have at least two or more chronic condition, which means that majority of Medicare patients have two or more chronic conditions. And of course, Medicare is spending most of its money on chronic conditions. So in 2015, Medicare heard from providers loud and clear that they were tired of doing all the work in between office visits and they were not able to get paid for it. CPT codes, people call it program. It's really not a program. It's just the CPT code to help you bill for the time that you spend in between office visits. So by 2019, Medicare had enough data to say, wow, like people that were billing for these services, the doctors, providers, had better satisfaction, patients had better satisfaction. And in 2022, this is really where CCM became super, interesting for people because Medicare actually increased the fee schedule by about 50%. And they let the RHCs and FQHCs also bill for CCM. And last year, or this year, there was really no changes, but there's so much coming down the pike. According to what Medicare just put out is their interim fee schedule for 2025. So let's talk about what is chronic care management. What is CCM? Medicare said CCM is the care coordination or care management that is happening outside of regular office visits for patients with two or more chronic conditions. So let's first talk about who are the patients that qualify to be enrolled in CCM. Any patient with two or more chronic condition should qualify for the service. Medicare provides you example of what chronic conditions could be. Keep in mind, what does a provider needs to do in order to be able to bill for CCM? What's very important is that there has to be a face-to-face visit within 12 months of starting CCM, the initiating visit. So before CCM starts, as I said, patient needs to be seen by the provider who's billing for it within 1 year or within 12 months. Consent. Consent is very, very important. It used to be written, which kind of stopped a lot of people from participating. But in 2019, Medicare said, okay, it could be verbal. So after the consent, you have to start writing a care plan. It should be comprehensive. Here's when I bolded all health issues. It's very important. Have a care plan for only two chronic conditions. You have to find a way to provide patient or their caregiver with a copy of the care plan. What is care plan? Medicare said comprehensive care plan for all health issues typically includes, but not limited to, the following elements. And so here's the elements. You have to have a problem list. It should be kind of living document. You don't want to make a care plan and then never look at it again, and then a year later just kind of glance it. So it should be kind of living document that you update all the time. So the question where a lot of people are still confused is, what can you bill for? Like, what are the CCM activities? So any type of care coordination, medication reconciliation, education, refills, lab review, preventative care. So let's talk a little bit about billing. Who can bill for CCM? Billing providers are considered physicians and the following non-physician practitioners, or NPP. Underline it. It's either physician, or majority non-physician practitioners are nurse practitioners or physician assistants who can and should be billing for CCM. Who cannot bill for CCM? Clinical psychologist, podiatrist, dentist, and remember, only one provider can bill for CCM per month. That's very important. Now, we know who can bill for it, but who can provide the services? What's important is it can be done under general supervision. So these providers hire clinical staff to do the work. Clinical staff can work for you as an employee or as a contractor, but they need to be allowed by law, regulation, and facility policy to perform the special tasks, and they need to meet any applicable requirements that provides the services, including licensure imposed by the state. I just want to show you here an example. After 22 payment increase, nothing really changed. Therefore, it kind of stops here at 2022 payment. As of 2022, we can bill CCM together with transitional care management. If you're billing for any of those codes, then CCM is going to be rejected. Principal care management. So this is basically, I would say, a maybe twin or sibling of CCM. Everything stays the same, except it's really for patients that you're taking care of one chronic condition. So if you're a specialist and you're taking care of one chronic condition, you do the PCM. The difference with PCM is that everything is built in 30 minutes increments and not 20 minutes. And the payments, you can see that 30 minutes by a provider is about $80, which is not much. So reimbursement opportunities, if we're talking just CCM and we're talking about only one code, 99490, which is 20 minutes financial benefits, 100 patients on CCM can generate about $80,000. So how can we make this happen? Let's say you want to make this happen in your office or in your practice. Well, number one, you need to think about your population analysis. So if we'll focus on Medicare patients, caseload should be about 350 to 400 patients. So then the question is, do we outsource the CCM or should we do it in-house? There's pros and cons in everything. So how do you think about when you're evaluating outsourcing the team? And when you are evaluating clinical team, you want to make sure, as I keep saying again and again, their licenses. You want to see if they have bilingual staff or they're using language line. You should see what open communication lines they have. You wanted to understand what their escalation protocols are, is to ask what are the attrition rate. And you want to make sure that their management are clinicians. Look for in the software, like, is it one trick pony? Are they only doing CCM? Do they also have a PCM? Maybe you want to do annual wellness visits or RPM. So just look for the softwares that do a lot more than what you need. So pros and cons to using EMR versus using CCM platform. There's a lot of challenges in this space. I can tell you that one of the most crucial is provider involvement or lack of. And best practices, I can say I have not seen a successful CCM program if they don't have team meetings, do root cause analysis of, who are the patients that got admitted or readmitted. You should have clinical conferences, and definitely you have to have a designated person on your team if you're a provider and you're outsourcing it. And with that, I want to thank you so much for coming and for sharing your time with me, and good luck to you implementing or maybe making your program better.
Thank you so much.
Thank you.
Okay. Thank you, Irina. Thank you, everyone, for your time. Have a wonderful day.
Bye-bye.
Bye-bye.